Let's talk about tension pneumothorax. Let's do a question. 56-year-old male with a history of chronic obstructive pulmonary disease COPD presents with pleuritic chest pain and trouble breathing. Vital signs are significant for blood pressure is 88 over 54, pulse is 115. On physical exam, there is jugular venous distension, decreased breath sound on right side, and wheezing. A chest radiograph is obtained, and it's completely black on the right hand side, and this indicates tension pneumothorax. Let's talk something about tension pneumothorax. It is a results from a positive pressure built up secondary to a flap valve, flap valve mechanism, which is a one-way valve, result in total lung collapse. There will be tracheal deviation to the opposite end, expansion of the chest wall. You can see the trachea has been deviated towards the opposite side. This is the pneumothorax side, and the trachea is deviated towards the opposite side. And so what does this valve do? If you want to see if this is the visceral pleura, this is the parietal pleura, and there will be a flap valve here, in which when we take the air in, the air moves only in this direction. It only goes out in the pleural space, and it does not come back in. So it is a one-way valve where there will be air moving in the pleural space from the lungs and not coming back, and that will cause the collapse of the lung because of the pressure that is building up in the pleural space. So there will be expansion of the chest wall, tracheal deviation to the opposite side. There is increased intrathoracic pressure, which restricts cardiac output and may result in shock and death. And because it restricts cardiac output, we can here see the shock signs, which is hypotension with tachycardia. Let's talk about the etiology. It could be penetrating or blunt chest trauma. It could be infection, positive pressure, mechanical ventilation. It could be iatrogenic placement of central venous line, or could be epidural thoracic catheter placement. Now let's talk about the presentation. The symptoms could be acute onset, unilateral pleuritic chest pain, which we saw in the question earlier, dyspnea or the acute respiratory distress, syncope. Let's talk about the physical exams. It could be tachycardia, tachypnea, which we saw in the question, unilateral decreased breath sound or the absent breath sound on one side, which we saw in the question again, which was on the right side, hyperresonance, because there is a lot of air there. So air will cause hyperresonance on percussion, especially on percussion. A decreased or absent tractile fremitus, falling O2 state, deviated trachea, JVD, hypotension, subcutaneous emphysema. So this all could be the physical findings that we could see. Let's talk about the imaging. Ultrasound, if we do fast with no radiation exposure, requires a bedside ultrasound readily available, guidance for the tube placement, it could be used. Ultrasound, chest radiography, chest x-ray. Do not obtain chest x-ray if tension pneumothorax is suspected. Why? Because we immediately have to decompress the pleural space, otherwise patient could die. So immediate decompression is the first thing to do. Do not go for chest x-ray if you think it is pulmonary. Sorry. So if you think it is tension pneumothorax, you don't need to go and confirm it with chest x-ray or ultrasound, anything. You just take a needle or anything sharp object. Immediate decompression is the first thing you do. Best observed in end expiratory films, It shows unilateral absent lung parenchyma and contralateral mediastinal shift. If we talk about the differentials, the primary spontaneous pneumothorax, secondary pneumothorax, acute asthma, inhalation of foreign object, myocardial infarction, ruptured aortic aneurysm. This all we could see. Tracheobronchial rupture, if a recurrent pneumothorax that recurs after chest tube placement, you could think of tracheobronchial rupture. If we talk about the treatment part, prevention, there is no preventive method that can be taken for initial insult. The chest tube placement following needle decompression prevents the recurrence. Let's talk about the other thing. Do not resolve spontaneously, and unlike small simple pneumothorax, you also need supplemental oxygen therapy. If we talk about the operative, the immediate needle decompression, which we already talked about, that's the first thing you got to do that. And where you gonna hit the needle or just pick the needle inside the chest, it would be second intercostal space at mid clavicular line with 14 or 16 gauge needle, and that would be followed by chest tube placement. Thank you.